Back to today's session for the online teaching program for postgraduates in pathology.
Good evening, ma'am.
Good evening, ma'am.
Today's discussion is regarding common scenarios in transfusion testing. It will be a case-based discussion. And to chair the session, we have Dr. Vijaya Patil ma'am, who is Professor of Anesthesiology at Tata Memorial Center in Mumbai. Our eminent speaker for today is Dr. Rajesh Sawant sir. Dr. Sawant is consultant in transfusion medicine, histocompatibility and immunogenetics at Kokilaben Dhirubhai Ambani Hospital in Mumbai. We have 8 participating postgraduate students in pathology today attending this seminar. I would request the participants to introduce themselves one by one.
Good evening, everyone. I'm Dr. Soumya Gupta from KMC Mangalore.
Good evening, everyone. I'm Dr. Ankita Site from Gandhi Medical College, Bhopal.
Good evening, everyone. I'm Dr. Shraddha Barate from Sri B.M. Patil Medical College, Vijayapura.
Good evening, everyone. I'm Dr. Sabarathina, Tata Memorial Hospital, Mumbai.
Good evening, everyone. I am Dr. Tanuj Das from Agartala Government Medical College, Agartala.
Good evening, everyone. Myself, Dr. Jayashree Das from Assam Medical College, Dibrugarh.
Dr. Ashwati.
Ashwati is not there.
Dr. Kishore.
Good evening, everyone. Myself, Kishore Yadav. I'm postgraduate in final year, Narayana Medical College, Nellore.
So these are the participating postgraduate students for the seminar. The moderators for today's seminar are Dr. Deepika and myself. The webinar hosts are our beloved teachers, Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. These are a few reminders for the participants. If there is any lag in the connection, kindly leave the meeting and rejoin the same link. Any answers to questions posed by the presenter are to be answered in the chat box. Similarly, any questions are also to be typed in the chat box. These are a few disclaimers regarding today's seminar. A few more disclaimers. The upcoming talks in the series include a talk on basic statistics for medical students by Dr. Priya Ranganathan ma'am. That is on the 13th of December. Ma'am is professor in the Department of Anesthesiology at Tata Memorial Hospital. The next session is a slide seminar, that is the third slide seminar on kidney lesions on the 15th of December, and that is by Dr. K.P. Aravindan, who was previous HOD in the Department of Pathology in Government Medical College, Calicut, Kerala. So let's start. Over to you, Sawant sir.
Well, thank you so much, Sharmila. And I take this opportunity to thank the organizers, Dr. Sumit, and everyone involved in this very, very effective online teaching program. A special thank you for thinking of this topic, especially for case discussion, because though all of us know that blood grouping is apparently a simple test, or transfusion related testing can be simple or it can be extremely complicated. There's a lot of haziness that surrounds the principles or the applications of these tests and the interpretation of these results. So with these 4 cases, we are trying today to kind of address all those issues that are generally faced by general pathology laboratory practitioners, transfusion medicine practitioners, and also clinicians who use transfusion services. So we are going to look at clinical implications of all these immunohematology principles also, right? So with this, I think I will just start sharing my screen. Okay, is the screen visible?
Yes, sir.
Yes.
Okay, so let us quickly start so that we get good time for our discussion as well. Right. So before we embark into the actual cases, I thought that it is definitely essential to pay our tribute and remembrance to all those great scientists who were behind this. And today we know the details of more than 30 blood groups and subgroups, and transfusion is happening and is saving so many lives. And if you have to sum it up into one name, that is Karl Landsteiner, who came from Austria, and he was awarded the Nobel Prize in 1930. And he is known as the father of transfusion medicine, of course. So let us come to few basics. All of us know that there are various blood groups, but we will today restrict ourselves to the ABO system. So we may either be A group, B group, AB, or O group. Okay. So when someone possesses the A antigen, he becomes A group. If you have the B antigen on your red cells, you are B group. If you have neither A nor B, you are O group. And if you have both A and B, you will be a AB individual, right? Similarly, it is worthwhile to also note that if you have an A antigen, obviously you can't have an anti-A isoagglutinin, because that will lead to agglutination of your own cells. So every A individual will have anti-B antibody. A B individual will have anti-A antibody. A O individual will have both anti-A as well as anti-B, and a AB individual will have neither anti-A nor anti-B. Now this is simple basic information, but it is very, very important, because practically when we look at choices of red cells versus platelets and plasma, the principles are different. When we look at the choice of red cells, we look at the RBC antigen that is present. Whereas when we look at the choice for plasma or platelet transfusion, we definitely consider the antibodies that are present in that individual's blood. Okay. So, and the to sum it up, O group will be the most commonly acceptable group for anyone, because there is neither A nor B antigen on the RBC membranes of a O group individual. But when it comes to platelets or plasma, will O group be equally safe? No. In fact, that would be the last choice. So here it will be AB. That would be the group of choice, because AB individuals will not have either anti-A or anti-B isoagglutinin in their plasma at all. So this is something which is the basic thing to remember. A little bit about inheritance of these ABO groups also. I'll not go into the details, but we inherit them from our parents, right? And we also have to understand that there is a genotype that is involved in this. What is expressed on our red cells will be our phenotype. Okay, so this is a busy table. You can get it in any basic reference of immunohematology. We will go further. Another important thing is all of us, 80% of us, are secretors of blood group substance. So we have the A substance or the B substance or the H substance, which is there, which is responsible for the formation of the A antigen, B antigen, and the H antigen, etc. And these blood group substances are secreted in the saliva as well as other body fluids. So whenever you have a scenario where the blood group is not very clear, or you're dealing with a possible subgroup, one test that you do in addition to the traditional blood group testing is the secretor screening or testing. 80% of us will be secretors, 20% of us will be non-secretors. So we may not have any blood group substance in our body fluids. Okay, coming to ABO typing. Again, very important here, because traditionally, even today, surprisingly, we see many laboratories just performing the blood grouping with anti-A and anti-B antiserum. That is it, and the anti-D antiserum. So you get a forward ABO group and you get a RH type. Okay, but it is very, very important to look at your serum group or your reverse group, where you test with known A1 cells, B cells, and O cells. Okay, so you have these pooled cells in your laboratory and you add the plasma or the serum of the patient or the donor whom you are testing. Okay, and what is the end point of this testing? It is agglutination or hemolysis, which is considered as a positive result, right? So the take home here is always compare the results of your cell and serum grouping and then label the blood group. The next important aspect here is the subgroups. So though we have clear-cut A group and B group and O group, but there may be subgroups also, like the most predominantly found subgroup is subgroup of A, which is A1 and A2. There are other subgroups which are quite rare, but there are a good 5 to 15% of individuals who type as A group who may be A2 subgroup also, right? So A2 individuals may have anti-A1. Okay, or they can be tested, the red cells can be tested with a lectin, which is known as anti-A1, which is also, the scientific name is Dolichus biflorus, right? There are also subgroups of B, which are less common. So with this background, let us come to our first case, and the discussion of this case will be done by Dr. Soumya and Dr. Ankita. So can we start with one of you? Dr. Soumya or Dr. Ankita?
Yes, sir.
You
So,
start discussing the case? Yes.
yes, sir, I'll start, sir. This is a case of 35-year-old male who came as a donor for renal transplant. Now, the known blood group was AB positive with no history of previous transfusion and no other relevant clinical history. Samples were received for typing and screening.
Correct. So from whatever is given in the introduction of this case, is there anything which you want to comment upon?
So, sir, actually, if any discrepancy is there, it can be due to sensitization due to previous transfusion. So here it is mentioned clearly that there is no transfusion.
There is no transfusion history. Perfect.
Yes, sir. Another thing, sir, first age. So sometimes discrepancies happen due to newborn or old age. So they're not able to present antigens properly. So that thing is also cleared in the history itself that it is 35 years old male.
Correct. Yeah. So we do not expect any, ill-formed or ill-defined antigens or antibodies. We expect them to be fully expressed, right?
Yeah.
Now, sir, one more thing worth noting is that there is no other relevant clinical. Some conditions like multiple myeloma where rouleau formation is there, or some cases like colon carcinoma or infections with gram-negative bacteria can cause acquired B antigen. So that is also ruled out here in the history itself.
Correct. Also, there is no history of any transplantation, say like a bone marrow transplant, where you can have chimerism or different blood groups, right? So that also gets ruled out, right? Is there anything related to renal transplant? Now he is a donor for renal transplant. Anything that you could think of?
Actually, what happens in renal transplant that we have to be very careful about the ABO grouping, as anti-A and anti-B antigens bind to the endothelial cell and start the complement reaction. So we should be sure about the ABO grouping.
Correct. And also, in fact, some accreditation requirements now, they state that you have to mandatorily do the A1, A2 or the subgroup testing for these individuals. So if you have a A group or a AB group individual, you have to go further and do the subgroup testing also. And if you find that that particular individual is A2, then you look for any antibodies because he may have received transfusion of A1 cells, in the past, and anti-A1 antibodies may be formed, right? So this is the relevant background. Let us go further. So here, this is a image of the blood group, which is done with column agglutination technology. What can you see here?
Sir, in this, anti-A is showing strong positivity, anti-B is also showing strong positivity, +4 positivity, and anti-D is also showing +4 positivity in the forward blood grouping, whereas in the reverse blood grouping, that A cells are showing some positivity and B cells are not showing any positivity, and the control is also not showing any positivity.
Right. So what do we interpret from this picture is the forward and the reverse. Like we said that you have to perform a forward blood group and a reverse blood group and match the results. So are the results matching here?
No, sir. It is showing that there is some discrepancy, ABO blood discrepancy in the reverse blood grouping.
Correct. So there is an unexpected additional reaction in the reverse blood grouping with the A cells, which in general are A1 cells.
A1 cells.
Yeah, because almost 85 to 90% of the donors will be A1. So the common cells that we have in store in our pooled A cells will be A1 cells.
A1 cells.
And there is a weak reaction with A1 cells. So that will be because of anti-A1, right?
Yes.
Okay, so let us go further and see. Okay, so the first thing that you also do in terms of your screening is your antibody screening. So we will talk about this a little later also, but you can see the results over here. So this is a 3-cell antibody screening panel. Can you describe the results?
So antibody screening we can do to check the presence of any irregular antibodies or the ones which are not naturally occurring. So here with 3 cell type, the antibody testing is done, and we can see that there is no agglutination or positivity seen in any of the 3 cells. So thus the irregular antibodies are ruled out from this test.
Correct. So there are no irregular antibodies. Okay. So we can do this antibody screening just with our pooled O cells also. Like in the previous slide, we had pooled A cells, B cells, and O cells, right? And also with a more specific, more phenotyped 3-cell panel. Okay. So this is a more specific screening for antibodies. Now, what we do as a reflex testing is that we test at 3 different temperatures using the conventional tube technique. So now we are testing at 4 degrees Celsius. So if there is any cold agglutinin, you can, understand the presence over here. You are testing at room temperature as well as at 37 degrees Celsius, right? Okay. And you have put up a anti-A, anti-B, anti-AB also. And you are testing with 2 different anti-D reagents. There is a control. You have A cells, which are essentially A1 cells, B cells, and O cells. Okay. So is the reaction differing in any way, anywhere at the 3 different temperatures?
Yes, sir. It's showing strong positivity at 4 degrees Celsius. Means a cold agglutination is present.
So that additional, what I mean to say is that the additional reaction with the A cells is there at all 3 temperatures.
At all 3 temperatures.
Yeah, it is not that it is only at 4 degrees and it has disappeared at 37. So this shows us that we are dealing with something which is reacting at 4 degrees Celsius as well as at 37 degrees Celsius, right? It is not a pure cold agglutinin. So in this case, if it were a cold agglutinin, then you will get this reaction as 4 plus or 3 plus positive, whereas room temperature and 37 degrees Celsius reaction will be negative. In that case, you can infer that this is possibly because of a cold agglutinin, which will be typically a room temperature reacting or a cold reacting antibody of IgM type, right? So let us move further. The next test that we do is a direct antiglobulin test, and the results of DAT are negative in this case. And we also test at 3 different temperatures for auto antibodies. So auto control testing is done, and here also the result is negative, right? So let us come to the possibilities, or how do we proceed with this case. So what is your comment going to be at this juncture?
Sir, at this point, we know that there is some additional antibody which is there. And since B is in forward grouping, anti-B showed +4. So that means B antigen is clear for us. It is there. And we have to look into A blood group. So
Correct.
Now A expected result in reverse should have been negative, but minimal amount of positivity is there. So something from A subgroup can be there.
Yes.
So to proceed, should test it with different antibodies from the A subgroup. So A subgroup we have A1, A2, A1B and A2B. So now then we should proceed with A1 cells and we can see that which one it is reacting with. It can be one of the subgroups of that.
Correct. Yeah. So before that, the first thing that you can do is you will have anti-A1 lectin, okay, with you. Here in this case, the testing with this anti-A1 lectin, the result is negative and the anti-H is positive. Why do we do anti-H testing? What does that signify or help us to rule out?
Sir, actually,
Any special blood group comes to your mind when you test for anti-H?
Bombay blood group.
Bombay blood group. Yeah.
Yes, the Bombay
Bombay
phenotype.
blood group.
Correct. So here we are ruling out Bombay blood group because with anti-H we are finding a +2 positive agglutination, right? But the anti-A1 is negative. Correct. That means the cells that you are dealing with are not having the A1 antigen. Correct. Now, in this case, you can do a further salivary group confirmation. And if you have A2 cells with you, you can also do the testing with A2. Correct. And you will understand that this is a subgroup of A, which we had expected. And the actual blood group of this individual is A2B. Correct. It is A2B and RH was not at all ambiguous. It was clear-cut positive. So we can release the report of this particular individual as A2B positive. Right. So when we deal with such discrepancies, first thing, the first take home here is that you have to do a forward as well as a reverse blood group and match the results of your forward and reverse blood group. Now, the practical issue around this particular blood grouping is, at least once every month we get such cases that a person has come to the hospital for, say, blood grouping and health check, etc. And when they get our results, they say, oh, for my life, I have been having this particular blood group in my iCard and all my records. And now you are saying that my blood group is not what I have, but it is something else. And we have to go back and collect a second sample just to rule out a wrong blood in tube, etc. But whenever we do the blood group, we find that whatever we have reported is correct. Now, why this happens is because most of the times these blood groups are done at laboratories, where only the forward blood group is done and a slide grouping is done. I'm sorry for the announcement. Okay, so slide grouping will have these limitations and therefore you have to choose the correct method for your blood grouping. So these days, now we have very good and easy methods for blood grouping. You have better slide, coated slides, etc. for doing your blood group, and the forward reverse matching of the results is what is necessary, right? So this is the main important take home from this simple case, right? Are there any comments from anyone, or Dr. Vijaya, do you want to say something at this juncture?
So chat box, no questions.
No, I don't want to say, but I have got few queries, Rajesh. Like when we do these cases, the renal transplant cases, many times it may happen that patients initially, when they're on dialysis, before they go on transplant, sometimes they do require transfusion. Though we say that the transplant patients, we should not be giving transfusion, we try to avoid it. But sometimes because of some complications, bleeding and all, and at that time, if they are not given, as you are saying, you have to do the reverse matching and all, which is not routinely done. So suppose if this patient has got A1 positive and he gets just AB, that A1 0, that other antigen, will it affect their transplant later on? Will it affect the matching of the donor with the recipient anytime? I'm talking about recipient because that is what we deal with.
Right. Yeah, so that's very important. Actually, now, if you are dealing with a transplant, then definitely this would be a hospital-based blood center, right? In all hospital-based blood centers, they definitely do a forward as well as reverse blood group. So the chances that this will be missed is very, very less. The only thing is, as a donor, as a normal individual, we may get our blood groups done at a pathology laboratory also, along with our other tests. And they may do it on a slide and not do a reverse blood grouping. This is where you may be reporting a different blood group. In this case, instead of A2B, it will just be reported as A1B or AB because they have not looked at further testing with the A1 lectin, etc. And
so are you saying that, sorry, each blood, wherever we get blood grouping done, they look at these things in detail because again, this transplant who are the recipients, many times now we have got so many dialysis centers. So I'll tell you, I have witnessed this, that while doing the dialysis, the patient develops problem, fistula bleeds, the patient bleeds excessively from the fistula. When they reach home, sometimes they continue to bleed and then they are reported back to the transplant centers, which are not hospital-based, not nasal, they're standalone transplant centers. And then there they procure the blood from whichever lab is available nearby. So do all the labs follow this strictly, or we have to be very, very specific when we get such patients who are potential recipients, that we see to it that the blood has to come from a good reputed organization or institute where it's both the things are done?
Yes, actually you brought forward a very, very relevant point. That first thing is that it is always a recommendation, like what we always tell, that whatever kind of transplant that you are planning, at the first visit, when the chances of the patient being multiply transfused is very less, it is better to have a blood group done. Right? And if your patient is likely to receive multiple transfusions, also get at least the RH phenotype done. That's very important because after receiving multiple transfusions, you may not get a clear-cut picture of the phenotype of that patient. That's one. The second thing that you asked about whether all centers will do this. So it's very important to choose the blood center where you are sending or referring your patient for transfusion support. All the hospital-based blood centers who are, very strictly governed by the FDA, they definitely follow this forward and reverse typing and also the major and minor cross matching. So this kind of discrepancy or subgroup will easily be identified by them. But the standalone blood centers, I really can't guarantee whether they will go into the depth of this, and that is where these things can be missed.
Because many times this is what happens. The standalone dialysis centers don't have their blood bank, and they get the blood from wherever.
From outside. Right. That's why it's very important that the treating doctor, the treating surgeon, physician, they explain the patient's family about the need to follow certain norms for transfusions and choose the right kind of blood center for getting the blood transfusion support for.
All the O negative bloods, like again, I have witnessed one patient who post-renal transplant had on third post-op day had massive bleeding. She bled almost 2 liters. Now, in those cases, if the patient's group-specific blood is not available, we generally ask for O negative blood. So, do all the O negative blood also means each and every unit is tested for this forward, reverse, and the proper thing is done?
Yeah, of course. So actually the subgroup is like related to the A group as well as the B group. When you're dealing with O group, we are lucky in the sense that, they lack both the A and B antigens. So there is no possibility of subgroup in that case, but the RH is very important in that case. So we will discuss in the next case about the importance of RH and interpretation of RH also.
Okay. Sir, we have a few questions now coming up. One question from Dr. Lucky is, can a baby have a RH positive blood group if the parents are RH negative phenotype?
Well, it depends actually. Again, here the RH typing, whether it was done at a proper center or not, because many a times weak D is misinterpreted as RH positive, right? Or also RH negative. It may go either ways depending upon which reagent you are using. So I will be able to answer this question with example in the next case actually.
Okay, sir. Another question from Dr. Amit is, what is the blood group of choice of a transfusion for such patients? I think maybe he's referring to the case that we have presented.
Right. So if your patient is just a subgroup of A, like A2 or A2B, but has not developed anti-A1, then even A1 cells will be compatible at the first instance. There will be no incompatibility. But you can, if you transfuse A1 cells in this case, then he can develop anti-A1 antibody, right? So it is always better to give A2B. So you have to screen your AB units or your A units with your anti-A1 lectin and give A2 or A2B units in this case. Or if that is not available, you can give even O group to these cases.
Okay, sir. Next question from Dr. Preeti. As you mentioned, sir, I did come across a pregnant lady wherein she was a known O positive group, but it came out and had to report as O negative with both forward and reverse grouping. But why does this happen? Change in the grouping?
So that is related to the D testing, which we are going to discuss in the next case. So we can discuss the answer that time.
Okay, sir. Okay. And next question from Dr. Pradeep is, by what age newborn can be given a confirmed blood group?
Well, in case of newborns, the RH antigen is quite robust, so you can report the RH antigen. But as per the guidelines, what we follow is at least for the first 3 to 4 months. There are some guidelines which specify 3 months, others specify 4 months. There are some who even specify up to 6 months of age. We cross-match the blood means transfusion support that is offered to a newborn or a very young child with the mother's sample also, for the same reason that their ABO group as well as the RH group antigens may not be developed fully. So only at the age of 4 to 6 months we can interpret the blood group of a newborn with confidence. So therefore, though you do the cord blood grouping or you have those records, but this has to be confirmed and it has to tally with your previous group at the age of 6 months.
Okay, sir. And last question from Dr. Raik is there any difference between slide method versus tube or column method?
Yes, there are a lot of limitations of using a slide method. Slide method is actually not at all recommended if it is the first test that is done and it is the only method or test that is done for interpretation and reporting of a blood group, right? The gold standard is still a tube method. Slide method is just used as a confirmatory method. If you already know the blood group and you are, say, going ahead with a transfusion at the bedside just to confirm at the last moment, you can use a slide technique for reconfirmation of blood group, but definitely not the primary, reporting should be done with the slide method.
Okay, so thank you. As of now, these are the questions. Maybe we can move on to the next.
So we can quickly move to the next case. So a little bit of background again about the RH blood group system. As we know, after the ABO system, this is the second most important system, right? And this revolves around the presence or absence of the D antigen, and which is present on the chromosome number 6. And this follows the autosomal dominant inheritance pattern. Okay, a little bit of history. You have to remember the names of, again, Landsteiner, Wiener, and Levine, who have worked a lot on the D antigen status, right? Clinical significance, again, 2 things to remember, that the formation of this antibody after exposure through transfusion or pregnancy definitely is reported and is known. Okay, so if you are exposed, if you are RH negative and you are exposed to the D antigen because of a transfusion or because of a pregnancy in a female, recipient, then you may form an anti-D antibody, but it will be only in 30% of the cases. So we see so many individuals, for example, RH negative female who has a RH positive fetus may not develop anti-D antibody always. Similarly, in case of emergencies as a life-saving measure, whenever you do not have a RH negative unit, it may be a negative, B negative, or AB negative or O negative. to save the life of that individual, you can very confidently you choose the corresponding Rh positive blood group and still save the life of that patient. That's very important to know, because the worst that would happen is formation of an anti-D antibody later on after a few weeks or months, right? That too, it will happen only in 30% of the individuals, but precious life will be saved in this case. So we have to understand these two clinical scenarios very, very properly, confidently. Okay, now the Rh antigens you have, apart from the D, you have the capital C and little c and capital E and little e. So that is the Rh system. So when I say Rh phenotype, that means we are testing for capital D plus these 4 antigens. Okay, we will show you the image also later on. Again, we have to understand the terminologies like weak D. Okay, now in weak D, what happens is that you see a clear-cut agglutination, but the strength of agglutination may be varying. So we will see this with the case also, and then we will discuss, okay, the clinical significance, etc. Right? So let us go to the case first. So I will now invite Dr. Shraddha and Dr. Sabha to discuss this case.
So here is the case of 41-year-old male for blood donor. The blood group of this patient is not known. The last donation was done 1 year back. There is no history of transfusion and no relevant clinical history.
Correct. So any comment on the case history that we have at hand?
Sir, he is a 41-year-old male, and he is a candidate for candidate of blood donor, sir.
Donor, correct. Yeah. So does male signify anything?
Sir, in certain cases, considering the Rh expression, there are certain variants of Rhd, which are partial D and weak D. In certain cases, in males, there is some they might lack some expression on the epitopes.
Yeah, that's quite rare. But the commonest thing here is, see, suppose if you have, instead of a male, here we say it's a 41-year-old female. So that means the chances that she remaining being pregnant in the past are high. In that case, you may have a scenario where there may be an antibody if the female is Rh negative, whereas it's a male, plus there is no history of transfusion. So we don't expect any discrepancy as such in such cases, right?
Previous sensitization won't be
Absolutely.
a possibility.
Right. There is no relevant clinical history also. So we just expect that this will be a clear-cut blood grouping that we will be reporting. So let us see what happens further in this case. We have the ABO grouping results over here. What can you see? ABO and Rh grouping.
So anti-A is showing strong reactivity.
Correct.
And also anti-B is showing mixed field agglutination, that is mild reactivity seen there.
Mm-hmm.
And also the reverse testing is showing anti-B antibodies.
Correct. So forward reverse, is it matching?
Yes, sir.
It is matching. So there is no ABO discrepancy as such, right? What are we dealing with over here? A mixed field reaction with anti-D, right? So here you can see in this well, which is the anti-D testing, you can see that there are cells which are there on the surface. Okay, that means they are agglutinated cells, and there are cells which have reached the bottom. So they are non-agglutinated cells. Okay, mixed field reaction or mixed field agglutination. Okay, let us go further now. So first thing that we do reflexly is look at any antibody, right? Yes. These days, the norm is that any new donor or patient, you always do the blood group and the antibody screen so that you know the baseline status of the individual. What is the result of the antibody screen here?
It is showing negative results, sir.
Right. So all 3 antibody screening cells, red cells, are showing no agglutination. So antibody presumably is absent in this case, right? Then we also proceed, since this is a blood donor, many centers now do the Rh typing of the donor also. So as I told you, there is capital C, there is little c, capital E, little e, right? And kel, and there is a control. So this is the Rh typing of the donor. Okay. So what can you see here? The donor is C positive.
Positive. And it is also showing strong reactivity to small c and small e.
Correct, right? So only capital E antigen is not there, right? Not there. And also kel negative. Okay. So again, as I said, we still consider the tube technique, the conventional tube technique, as the gold standard. So the blood group was repeated over here with the tube technique, right? So forward and reverse, do you see any discrepancy?
No, sir.
No, right. But what do you see with the D testing? Now here, what we have done, instead of one reagent, 2 different reagents have been used. Right?
From different manufacturers.
From different manufacturers. So there is one which is the IgM type reagent, which is showing 1+ agglutination. The other manufacturer, also IgM type, is showing 2+ agglutination. And there is one more that was used, which is a combination of IgG plus IgM, right? And that is showing 1+ agglutination. So how would you interpret these results?
So this monoclonal anti-D2 is showing a positive, strong positivity, while the monoclonal IgM and polyclonal IgG are showing weak reactivity, and only monoclonal IgM is showing weak reactivity, sir.
Correct. So what would you interpret? Is the D antigen present or absent?
So D antigen, it is weakly expressed.
Yes, but it is present, right?
Yeah.
Okay, let us go further and see what was done. Okay, so as supporting test, you rule out certain things. So you are doing a direct antiglobulin test, it is negative. You rule out auto antibodies by doing auto control testing at 4 degrees room temperature and 37, and they are negative here, right?
Yes, sir.
Okay, so how do we report the blood group of such an individual, and are there any considerations that you will make? So both of you, Dr. Sabha also can join in. Do you want to comment on these questions?
Yes, sir. Like the patient is showing variable agglutination for the D antigen.
Correct.
So we have to do the confirmatory test for the subtyping of the variants of D antigen.
Correct. Yes, there are reagents available. So you have different type of variants of D, or which we call. So there can be partial D or weak D, D1, D2, D6, etc. There are different variants. So basically, in such individuals, what happens is that the D antigen is present, but certain epitopes may be missing. That is why with monoclonal, you can see that there is a good agglutination, and with polyclonal reagents, there is a mixed field or a weaker agglutination, right? So the confirmation here in these cases can be done by molecular testing. Okay, so what is the most important thing over here? We had questions also from the audience, and also our chairperson was asking about certain individuals who were tested either Rh positive and later on labeled as Rh negative, or vice versa, which is more commoner. We have individuals who say that I'm Rh negative for the whole of my life, and now you are saying that I'm Rh positive. So these are such individuals where their grouping may have been done just on a slide, or may have not been done with two different reagents, and they may have been labeled like this. But if they have mixed field reaction like we saw, or varying reaction, so there is weaker variant or a variant of D that is present. In that case, this individual will be considered as Rh positive as a donor. So suppose now we were dealing with a donor, right, in this case, right? So that donated unit will be labeled as Rh positive. But such an individual, if he has to receive blood as a patient, then he should be considered as Rh negative. He has to receive Rh negative blood, because if he gets a Rh positive blood, remember that his D antigen is not complete. There are certain missing epitopes, right? And if the transfused blood has got those antigens, then his immune system is going to still produce antibodies against those missing epitopes, right? And there will be formation of anti-D antibodies. Now, in a male individual, this may not be of much significance, but this is very, very significant for female individuals, especially in the childbearing age group. And that's why the baseline testing of any obstetric clinic, we always advise that please do a proper Rh typing along with the RHKL phenotyping, and also do an antibody screening. That's very, very important at the first visit, so that you have a baseline. So if anything goes wrong, there is a transfusion, there is some alloantibody developing or autoantibody developing, then there is no ambiguity, or in case of any emergency requirement of blood, you know what you are dealing with and what you should give, right? So is that very clear to everyone?
Yes, sir.
Right, so I can just go back here. Yes, so here, as I said, if you test differently for a donor and a recipient sample, rather, your interpretation will be different. As I said, if your anti-D test is positive, okay, then you definitely consider as a donor this individual as Rh positive, correct? But if your anti-D at the IAT level is negative, then you will interpret this as a Rh negative individual. When it is a patient sample, you will interpret it a little differently, right? That is one thing. And as we talked about the significance, as a donor, you will be typed as positive. As a recipient, you will be considered as negative, right? So that is the most important take home in this case, right? Any questions from anyone, from our chairperson, or any discussants?
We have a few questions.
As I said, no comments, but few questions. Now,
Sure.
all these antibodies that you're saying, anti-D antibodies, they are basically proteins, so they must be having some half-life, or do they last? Because if there's no stimulus with a half-life, they should just disappear, isn't it?
Yes, but the anti-D antibody is quite robust. I mean, they remain in circulation for quite a long time. That is one thing. Second thing is, the most dangerous phenomenon is anamnestic reaction. So over a period of time, their titer may come down, and if you are not detecting them, but if by chance, because of mistyping of the blood group or non-confirmation of the blood group, if you land up transfusing this patient with a Rh positive unit, then there will be a florid anti-D production and destruction of those cells from the circulation. So that leads to almost like a hemolytic transfusion reaction. And that's what happens in the HDN. The first pregnancy, there's absolutely no problem. But in the second, there is a significant hemolytic disease, and the newborn suffers.
Okay, so we will say that even if their titer goes down, we'll always then consider them as they have been sensitized.
Correct.
If you say that only 30% patients who get Rh positive blood will develop antibodies, we have always been taught that during pregnancy or during peripartum phase, like we get the patients of these antepartum hemorrhages or postpartum hemorrhages, where if the recipient is Rh negative, and as you said, like, if you don't have Rh negative blood, do give Rh positive. So we have been always told that if we give Rh positive, we're supposed to give them anti-D anti-sera.
Yes.
Only 30% patients develop. Is there any way that I can wait for some time and see whether she's going to develop antibodies and then decide about anti-sera, or irrespective of that thing? Is there a period that I can wait and test this patient?
Yeah, so as per the guidelines, we have to give the immunoprophylaxis within 72 hours. After that, it does not really become relevant, because already the antigen presentation will happen and the sensitizing will happen of the immune system, right? So we cannot wait. But this is basically to guide the clinical transfusion guidelines in emergencies, especially when we are dealing with male patients and females in the non-reproductive age group. because male patients, even if they develop an anti-D, it is not really going to harm them much. Similarly, females who are not in the reproductive age group or who are not likely to, remain pregnant, they have already completed their family. The decision making becomes very, very simple in emergency situations. That is what I meant.
No, that's true. That is what we also follow. So what I'm saying is, patient coming in the first pregnancy, she's likely to go. So within those 72 hours, there is no way that I will know whether she's going to develop antibodies or not.
Yes, yeah, we cannot predict.
There's no test. Okay. Right. The third question is regarding our patients where we use massive blood transfusions intra-op, and patients require. So generally, after 5 or 6 units of transfusion, the blood bank asks for the repeat sample for cross-matching. So if you are doing all this forward and reverse testing, and we are so before we are transfusing, we are pretty sure that there's a chance of mismatch are going to be very minimum. In those cases, why do you insist for getting a repeat cross-match sample after say 6-7 blood transfusions? So what is the purpose behind it?
Yeah, no, actually, if I understand the scenario correctly, see, there are two things, Dr. Vijaya. One is if you are anticipating a massive transfusion, then the guidelines, the protocols, they say that you have to draw the sample in advance, because once you transfuse about 4 units to the individual, no longer the blood in circulation is the native blood of the individual, it is transfused cells also equally, right? So you need to draw at least one additional tube so that further cross-matching can be done with the native sample of the individual. That's one thing. Most of the times, if this is missed or this is not done, then there is another concern is if at all you are dealing with a case where antibody formation is a possibility, then the antibodies form very fast within a few hours also. And then you need to screen that individual for those particular antibodies also along with your cross-matching. So that is the reason why the second sample, the subsequent sample is asked. But the preferable testing should be done with the initially drawn sample of the patient, because if you are drawing a sample after transfusion of 4 or 6 units, it is essentially not the native sample, but the transfused sample.
Okay, so you are saying that every case where we are expecting massive blood loss, we should draw additional sample. And for Absolutely. How long that sample can be kept at the room temperature? Or we can keep it in the OT itself before, or we need to send it to
it has to be sent to the transfusion services so that they keep the sample. Actually, a sample is valid for any cross-match for 72 hours after the collection. And the sample is retained in the transfusion services for 1 week.
Okay, so it's not that because of the multiple transfusions, you're expecting that there'll be more antibody things and you want to check it. Okay.
No.
Thank you.
Sure.
Yes, sir. We have a couple of questions in the chat box, sir. Dr. Pradeep has asked, can we give the mother's blood group PRBC till 3 months of age to newborn babies?
Yes, so you cannot directly conclude that yes, mother's group is the best group, because there are different combinations. See, there are permutations, combinations. You might have a mother who is A group and a baby who is B group also. That's also a possibility, right? It depends on the blood group of the father as well, right? In such cases, you choose O group, which does not have either A antigen nor B antigen. Correct. In fact, many centers, to avoid any kind of misinterpretation or wrong decision making and to make things simple for neonatal transfusions, etc., they recommend O negative transfusions only, or at least O group transfusions if both the mother and child are testing positive for RH system.
Another question from Dr. Swati. Antenatal ladies will have mostly DU variant. What should be done for these cases? And Dr. Babita has asked, can you please explain DU?
Explains?
DU.
DU. Okay. So yeah, so DU actually is not the terminology that we use now. So we use variant of D. That's the thing. And as I said, like you have a D antigen, okay, which is present in parts. So there are different epitopes of this D antigen. What happens in these variant individuals is that some parts of the D antigen are missing, but other parts are still there. So your reagents that are used for D testing will give you variable results. They will either give you a mixed field result or they will give you a weaker result, 1+ agglutination or 2+ agglutination. It will not be a 4+ agglutination, right? But because some part of the D is missing, they have to be careful, especially when these are female individuals, female patients, and who are likely to remain pregnant. As I said, they have to be treated as a O negative or a D negative individual, as a recipient. So the gynecologist also needs to be advised that please treat this individual as a RH negative pregnant female. So she receives all the immunoprophylaxis and other things. And there are clear-cut guidelines, special and specific guidelines for this D variants of their management. But the basic, to make it very simple, you have to remember that as a patient, these patients are treated as RH negative, just to avoid any kind of anti-D antibody formation.
We have another question from Dr. Datta. He asks about the importance of capital C, small c, capital E, and small e.
Yes, very good question, Dr. Datta. And thank you for asking this. So basically, as I told you, the D antigen is also having this capital C, small c, E, and little e, right? So that is your RH subgroup or RH phenotype. This is very important in patients who are likely to be multiply transfused. Okay, for example, thalassemia individuals. So once you know their phenotype, what the blood centers now do, because most of the blood centers are also doing the phenotype of their donor. So suppose you have a patient who, I'll just go to the phenotype here. So suppose you have a patient, for example, this is a patient who is negative for E antigen. Then it is better to proactively transfuse E antigen negative individual's blood only to this case, so that this individual does not get exposed to any E antigen and he does not form an anti-E antibody. So if you prevent the formation of any antibodies by looking at the phenotype of such individuals by giving them the particular phenotype negative blood for which they are negative or which antigen is absent in them. Right? So that is very important. Like another example I can give you, we'll also discuss in the next case, is most of us will not have the KEL antigen. So if you have some donor unit who is KEL positive, which may be only a 2% possibility, then we see to it that we transfuse that unit to only a KEL positive recipient, because KEL is very immunogenic and it will quickly form an anti-K antibody, right? So that's the significance of doing a phenotype.
Dr. Jayasri has asked what is weak D and partial D and how to detect.
Yeah, so as we have already seen here, weak D will be with, like for example, in this case, you are getting a positive result with both IgM as well as blend, that is IgM plus IgG reagents. So that goes without saying that D is present. Okay, it is not showing any negative reaction at all, but it is weaker agglutination, isn't it? So this is more likely to be a case of weak expression of the D antigen. All epitopes are there, isn't it? You are not finding any non-agglutination with any of the reagents, but all epitopes are expressed weakly. Whereas in partial D, what you will get is maybe with your monoclonal reagent, there is a positive agglutination or weak agglutination, and with one of the monoclonals, you may find a negative or absent agglutination also. That means that particular epitope is totally absent, correct? So therefore, you have to use at least 2 different anti-D reagents for testing your D type. Otherwise, you may miss this kind of a reaction. And you, whatever with that one reagent, if you are getting a no agglutination, you will report that individual as D negative. So that individual will go around with a RH negative report, whereas actually it may be a case of partial D.
The next question is from Dr. Vishal. He asks, how does weak D differ from mixed field appearance in interpretation?
Weak D will be weak agglutination, right? Whereas mixed field will be partial D many a times, because there will be some cells which are lacking that particular epitope, okay? But only on the basis of mixed field agglutination, you cannot differentiate between weak and partial D. You have to look at the results of your monoclonal and the blend anti-D reagents.
We have a question from Dr. Lee, who asks if a weak D patient can produce anti-D in any circumstance. If no, can we still transfuse these patients with RH D plus, D positive?
Yes, that's again a good question. So as I said, weak D individuals will have the D antigen, all the epitopes will be present, but they will be weakly expressed. So it is very, very less likely that such an individual may develop a anti-D antibody. But yes, you cannot just wait at just your differentiating test like what we have done here is just tested with D1 and D2. In that case, we have to go further and do the complete variant testing. Okay. And then if you are sure that this is weak D, then that individual can get a RH positive transfusion. Moreover, if it's a male patient, it becomes decision making becomes simpler. But if it's a female and who is going to go ahead with pregnancy, etc., then you have to again confirm. So for any kind of RH variant, it is always recommended to do the genotyping. Now, genotyping is available at centers like our KEM hospital, the National Institute of Immunohematology. They do genotyping of such individuals and they give you the clear-cut picture whether this is a missing epitope or a partial D or a weak D, etc.
Dr. Piyush asks, while doing AHG test, anti-human globulin test, when blood group is negative, to rule out weak D antigen, which type of anti-D should be used, IgG or IgM or blend?
A blend, definitely, but you should not interpret with a single anti-D. As I said, at least use 2 different anti-Ds, of which one monoclonal and the other should be polyclonal or a blend.
He also asks how to report such weak antigen in routine practice, because on slide method it is looking negative, but on microscopy it is positive.
So that has to come with a comment. If you are getting such an observation, you definitely give a comment that further confirmation with confirmatory test in a blood center is recommended. And in the meantime, as a donor, this individual can be considered as RH positive. However, as a recipient, he may be considered as RH negative till complete resolution of the D status is done with a genotyping or a molecular test.
We have a similar question from Dr. Nasrina, who asks, how can we give the report of grouping in case of weak D?
Yes, so the same comment, the same comment which I mentioned just now has to be there.
We have a question from Dr. Mafruha, who asks why the donor of a kidney transplant needs to be ABO match, whereas in a bone marrow transplant, ABO mismatch can be allowed.
Yes, so that is because if you look at the physiology, the renal tubules, they express a lot of ABO substance, right? Not that we do not do across ABO blood group also. These days with improved immunosuppression, we do across ABO group renal transplants also. That has been done, but it has to be done in with a lot of monitoring, especially of the antibodies, the isoagglutinins have to be monitored, and a lot of care to immunosuppress the recipient has to be taken. But bone marrow transplants across ABO group are a common norm. They have also been done and established properly. So in today's era, that's not a contraindication. The ABO mismatch is not a contraindication for transplant, both for solid as well as bone marrow transplant.
Yes, I think that there are no more questions for now, sir.
Sure. So yes, so let us go to the next case. So as I said, a few things we need to know is that apart from, so we have now graduated from the ABO groups, and we know that apart from the ABO and the D type, there are various other blood group systems also, like the MNS, the KEL, KID, Duffy, etc. We have looked at the RH phenotype also, so I'm sure all of you understand that well and don't get confused. So now we are talking about the other blood group systems apart from the ABO and the RH. So this is the list of the various other blood group systems, amongst which the KEL system is the most very strong, very immunogenic, right? And you can have an anti-capital K or anti-little k antibodies, right? As I said, over 90% of our population is K negative, and it is not difficult to find compatible blood for a patient with anti-K, right? But we have to understand that if someone is KEL positive, it can be very, very immunogenic. So giving KEL positive blood to a KEL negative individual can also produce these antibodies. So with this background, let me invite now Dr. Tanuj and Dr. Jayashree for discussing this case.
The 70 years female diagnosed as CA tongue, posted for surgery, and they request received for 2 PRBC reservation. No
Right.
major surgery in the past, and patient blood and indirect agglutination test was performed 15 days back. Patient typed as O positive and IIT was negative. And during this period, transfusion received by the patient.
Correct. So the most significant thing in this is that the patient has a recent history of transfusion. So we can wait for some surprise, right? When we do the blood grouping or antibody screening, etc. So let us see what we are seeing here. The blood group is being typed as O. So are we seeing the same on the card here?
Yes, sir. It is O positive in forward grouping also. In reverse grouping also, we can see it is a O positive group.
Both anti-A and anti-B is present, right? And the D status also looks clean?
Clean, sir. It's
Absolutely.
positive. Yes, sir.
Okay.
And sir, IIT, yes, sir. Indirect agglutination test came to be negative, sir.
Okay, so here the IT is negative. Then the next that you do is since this is a patient who will need blood transfusion, you just don't wait at the IIT level, you go for the 3-cell antibody screening. And what do you see here?
Sir, after doing the antibody screening test, we saw that, sir, in cell 1 it came to be positive, but in cell 2 and cell 3 it is negative, sir.
Negative. So your antibody screen result is positive. So that seems to be some antibody that we are dealing with. Okay.
Yes,
so just to explain you over here, this is the schematic representation of the antigram. So you have cell 1.
Yes, sir. Cell 1.
And this is the list of various antigens that are present on this cell 1. So plus means present. So this particular, the cell 1 is having D antigen. So it is positive. Right? Cell 2 also has got D antigen, but cell 3 has D negative. So that is how you interpret. Now, if we go back to the results here, cell 1 is positive. Cell 2 and 3 is negative.
Negative.
When you interpret, you look at the same pattern.
Yes, sir.
Which are the particular antigens which may lead to a positive reaction with cell 1 and negative with cell 2 and cell 3. So you are seeing that with C, you are getting such a type of reaction. With capital K, you are getting similar reaction. And also with capital S, you are getting a similar reaction.
Same result. Yes, sir.
Correct? Okay.
Yes, sir. Yes, sir.
So let us go further. Next, what you do is you test with your
11 cell RBC panel, sir.
So this will be like identifying the antibody. So there you have zeroed down upon possibilities. So the possibilities will include anti-C, anti-K,
and anti-S.
Yes, correct. And now you put up your 11 cell panel. Okay.
Yes,
so your 11 cell panel will have cell 1 to cell 11 as the name suggests, and the antigenic make of these cells will be different. So you can see plus means presence of that particular antigen, and a 0 will be absence of that particular antigen. Correct?
Yes, sir.
So let us see the results here.
So in cell 2, cell 5 and cell 7, we got positivity, and with the rest of the cells are showing negativity, sir.
Negative. So it is very specific. So you are more likely to, when we get such a result, we are very happy that, okay, there is no confusion. Maybe it is a very specific antibody. Sometimes you get mixed field reaction, or you get, a weak agglutination at all cells, and then there is definitely a bigger problem, right? So this particular pattern of positivity, you said cell 2, and then cell 5, and cell 7, positive.
Yes,
okay. It is directly corresponding with a particular antibody against capital A antigen. Okay, this is not the way in which we interpret, but now for simplicity, I'm just explaining you this way. Otherwise, we look at the homozygous versus heterozygous expression and various other things. So there are different rules for actually reading and interpreting the antigram of 11 cell panel. But since you will not be doing this on a routine basis because this is a little advanced immunohematology, I am restricting to this particular approach. So here, what you identify is this is possibly a
K antibody
against the K antigen. So what you need to also ascertain before jumping onto the conclusions is what is the phenotype of this person. So for forming a K antibody, this individual has to be K negative. Isn't it? Only if he is negative, he can form an antibody, right? He or she, right? Okay, so you do the RH-KEL phenotype, and here you can see that this individual is negative for K, right? Also, routinely you do a direct antiglobulin test and do a auto control test to rule out any autoantibodies. All these are negative in this case. Right. So, can we answer these questions easily now?
Yes, sir. The antibody here we can find is, sir, anti-K antibody.
Okay.
Yes, sir. So clinical significance is, sir, if there is, because, sir, next to ABO and RH grouping, K is very much immunogenic, as you already told, sir. And we have to be very much careful with that before any, because it can cause hemolytic transfusion reaction. Even hemolytic disease of fetus and newborn also, it can cause transfusion reaction.
Definitely, yes.
Yes, sir. Yes, sir. And sir, we can proceed with transfusion support, sir. We have to give Cal negative blood here.
Correct. So you have to know the phenotype of the donor unit that you are dealing with, isn't it? Right?
Yes, sir. Yes, sir.
Right. So antibody screening, as I said, so we look for the various other blood group systems like Duffy, Kel, KID, MNSP, Lutheran, etc., etc. We have to also understand that some of these antibodies may be of IgM type. That means they will be reacting only at room temperature or older temperatures. Whereas if they are IgG type, they will be detected at 37 degrees Celsius. So please remember that you have to subclassify your antibodies. So generally the room temperature reacting ones are considered as clinically not very significant. They are known as nuisance antibodies because you will get a positive reaction, but actually it may not cause any harm to the recipient. Okay, so you have to always interpret your results at room temperature as well as 37 degrees Celsius in the antiglobulin phase, right? So moving forward, this is the recommendation for selecting the blood for patients with red cell antibodies. Okay, so if you have suppose any antibody against any particular, suppose here you can see anti-K, right? So what is recommended is antigen negative.
Negative.
Right. In certain cases, it may not be, like for example, if you have a anti-KPA antibody, okay, which is a subtype of the KEL system only. It's very difficult to type this particular antigen. The anti-sera may not be available. The donor, means the frequency of this antigen may also be difficult to find. In that case, you can do a IAT cross-match. And if the unit is compatible, you presume that that particular antigen may be negative, and you cross-match, means that cross-match compatible blood can be issued for transfusion to this patient. Correct? So there are certain straightforward cases where a antigen negative unit is recommended, like anti-M. Very common, which is active at 37 degrees Celsius, you pick up a M antigen negative unit. But for certain other rare cases, even a IAT cross-match compatible at 37 is a good option, is an acceptable option. You will not be liable to any litigation, or you're not doing any wrong to your patient, right? So this is what I wanted to bring back home here. Also, here I think it is very important and pertinent to discuss the ideal time of sample collection for pre-transfusion cross-match. Many a times, because of logistics and other things, we may think that, you know, why a fresh sample is needed, or cross-match to kiya tha, so can we use the same blood? What you need to understand that antibody can be formed as early as 48 to 72 hours also. So traditionally, we have been, looking at validity of 72 hours for a cross-match if a patient has not been transfused. But now there are some case reports where antibody is formed within those 72 hours also because of a previous transfusion. So if someone has received a transfusion, it is best to take the sample 24 hours before the transfusion that is planned, right? So that is something which you all need to know. This we have already discussed, so we need not go into the details of this. So finally, the interpretation, do you want to again come back with the interpretation here? This is an anti-K antibody, right? And as you said, capable of causing both hemolytic transfusion reaction and HDN. So what you do is K antigen negative units were cross-matched and they were found compatible at both room temperature and AHG phase, right? The patient luckily did not need any transfusion, so absolutely no problem, and the patient was stable also, right? So we can have questions.
Yeah, so Dr. Mafruha asks whether a KEL negative patient with anti-K antibody, can he be a donor for other KEL negative recipients?
Yeah, absolutely. That is not a problem, because now as a mandatory testing, we also screen the donors for antibodies. So if there is any antibody in a donor, that also will be detected, and we may not use the platelets or plasma for obvious reasons, but the red cells can still be utilized for transfusion.
And, Dr. Jayasri asks, what is the current policy of antibody screening in antenatal patients?
So antibody screening, in fact, for all patients in good institutions and accreditation requirements also specify that all patients who are likely to require any transfusion should be screened at least once for the presence of these irregular antibodies. What is important or what is variable is the technology that is used, because there are still some centers who just use pooled O cells for antibody screening even in patients because of various reasons, cost, logistics, etc. Whereas what is recommended is at least for the patients you use a proper 3-cell antibody screening panel.
Okay, sir. There are no more questions as of now.
So Rajesh, one query from my side is many times we for these patients, like surgical cases where we expect that as massive blood loss or whatever. And suppose if I have reserved 8 units of blood, which has been cross-matched on the previous night, I utilize a couple of units because patient does not bleed immediately. And then maybe he bleeds after 24 hours, rebleeds in the ICU and comes for the re-exploration, or I need to give transfusion after another 24 to 48 hours. So you mean to say I need to send, even if it is from the same institute, we have done the stringent checking, I should be sending a fresh cross-matching sample? Because many times we do not send, okay, patient at 10 reserved, abhi patient bleed ho gaya, and you give us 1 unit types.
Correct. Yes. So as I said, the 72-hour interval has been the norm that is being followed. Even today also we follow the same norm, but there have been, with improved antibody detection and screening methodologies, there have been cases that have come up where within even that span of 72 hours, because some transfusion has happened and the patient is immunologically very reactive, the patient has developed an antibody in that period, and suddenly you are finding that the units that were compatible 2 days back are now showing some mild incompatibility or 1+ agglutination. Many a times what happens is you may not detect incompatibility at that time, but after about 8 to 10 days, we call this as delayed hemolytic transfusion reaction, we find that the patient's hemoglobin falls, you do a DAT and the DAT is positive, and then you do a 3-cell panel antibody screening and identification, and you can find a particular antibody that has developed which was not there previously. So as a matter of abundant caution, what we do is, if someone has received a transfusion, it is always better to do at least a antibody screen repeat. Even if you don't cross-match, you can quickly do an antibody screen on the recipient and go ahead with those units that were cross-matched within 72 hours.
We should be sending this to look
Yes,
at.
that would be really, really very safe.
Okay. No, but the other thing is that now that if you're saying, I'm wondering, because many times our patients do drop hemoglobin after 4 or 5 days where you don't have obvious surgical bleed. And then we generally say that, okay, it may be because of iatrogenic, because we keep on withdrawing the samples, sending for the investigations. So
Correct.
in those cases, what would be your threshold? Yeah, so what would be your threshold to test for the antibodies? How much hemoglobin drop would you say? Is there any threshold set that suppose my patient's hemoglobin was 8.2 yesterday and today it has dropped to 7 and there is no surgical bleed, we should get it tested? Or is there any threshold set that drop in hemoglobin?
No, there is no threshold as such, but what we consider as significant is if there is unexplained hyperbilirubinemia, so we'll find a increase in the bilirubin levels, indirect bilirubin, and also you will find that the hemoglobin is gradually falling, after 8 to 10 days, and there is no other explanation for that falling hemoglobin. Then the first thing that you suspect is a delayed hemolytic transfusion reaction. Just send a direct antiglobulin test, which may turn out to be positive if there is some new antibody, and do an antibody screening. You may find that there may be a new antibody that has appeared.
A few more questions, sir. Dr. Mafruha asks, is acquired B group recipient, which blood group can be transfused?
Well, in acquired B group, if you are able to differentiate whether it is indeed acquired B group or so, in such cases or all such cases, it depends on the situation whether you have time to resolve or not. But then O group becomes very simple to transfuse, and even B group also should be okay. But O group is the most recommended in that case.
Dr. Amit asks, if AHG crossmatch is compatible, are there still chances of KEL mismatched transfusion reaction?
If AHG crossmatch is compatible, then that means there is no antibody that is currently there which is going to cross-react with the transfused red cells. It has no bearing on whether there is a mismatch between the minor blood group antigens or not, or KEL or capital C or little c, because that is the phenotype. The phenotype may still be different, and we may be adding a antigen that the recipient is negative for. But if it is the first instance, there is no antibody, your IIT will be still negative.
Dr. Jayasri asks, for donor screening, are 3-cell panel used in all donors?
No, it is not a mandate currently. So you may use pooled O cells also for donor screening, which still many blood centers are using. And of course, if there are resources available, you can use a 3-cell panel for your donor screening.
Those are the questions for now, sir.
Sure. So thank you so much. We move to the next case, which is the last case. And we have again here Dr. Aswati and Kishore. So has Dr. Aswati joined?
Yes, sir.
Yes, sir.
Okay. Great. So one of you, Dr. Aswati, Dr. Kishore, you can take up this case.
40 years male, diagnosis hemolytic anemia, hemoglobin 5.7 grams per deciliter. Blood group is not known. No history of transfusion, no history of major surgeries. Need PRBC transfusion.
Okay. So what is your view about this background?
Since it's a age group of 40 and male patient, diagnosis of thalassemia, which is thalassemia cannot be made under G6PD deficiency or any other hemolytic conditions that occur, can be ruled out, and blood group.
No, here we have already given the diagnosis that he is a known case of hemolytic anemia, right?
Yeah, sir. Okay. No history of transfusion. And no history of major surgery. Major surgery in sense, for sickle cell anemias, they do splenectomy prophylactically. So there is a ruling out of a sickle cell also here, and frequent transfusions are also not done.
Correct. So this is a case of hemolytic anemia. So you have to think in terms of what would be the differential diagnosis of hemolytic anemia, since there is no transfusion. So he has never required any transfusion at all, right? Isn't it? So obviously this will rule out thalassemia or sickle cell anemia or the other common hemoglobinopathies, right? What may remain with you as a differential diagnosis is other rarer hemolytic anemias, isn't it? Because of enzymopathies, etc., or the autoimmune component of hemolytic anemia, isn't it? Right?
Yes.
So you proceed. The first step, you do blood group, of course. So what are you seeing here?
Blood group anti-A4+ reaction, anti-B0,
anti-D 4+ reaction. Control is 0. 4+ reaction with B cells.
Correct. So is there any discrepancy in the results? What is the ABO group?
The patient has A positive, no discrepancy in forward and reverse.
Absolutely. So you can clear cut give a report of A RHD positive in this case, right? Then you go for the IAT. Okay. And what do you see over here?
It's 1+ reaction.
Yeah, so there is some antibody. 1+ agglutination is found here. And IAT, that means it is also IgG type, correct? Then you do a more elaborate antibody screening with 3 cell panel, cell 1, cell 2, and cell 3. What are you seeing here?
3 cell panel.
All the 3 cells.
Yes, so there is agglutination. That means all the reagent red cells are agglutinated to more or less the same degree, 1+ or 2+. So it is not a very strong antibody, but it is of weak to medium strength over here, right? But it is across all the 3 phenotypes, all the 3 screening cells, right? So this is a pan agglutination. Then you
3 cell panel.
Yeah, so this is your 3 cell panel. Now you go for your 11 cell panel. Again, what is the result here?
Pan-reactive.
Correct. So pan-reactive and +2. So uniform pan-reactive pattern, what does that signify? In this case, it is more likely to be a autoimmune
hemolysis.
or auto-antibody case, isn't it? Again, you try to confirm the phenotype, the RH phenotype. Are you getting clear-cut results here?
Yes, sir. It is not a kill antigen, it is RH.
Right. So here, this individual is capital C positive,
and small
little c is absent, and capital E is negative, and little e is present, right? KEL negative. So you know the phenotype. That's a good thing because you can give RH KEL matched blood. Then you do a DAT, which is you looking +4 positive over here, and you run your auto controls, right? Now, what would you like to comment, one of you, on the auto control results?
So it is positive across different temperature, but more strength is shown at 4 degrees Celsius.
Right. So the cold component seems to be more strong, right?
More strong.
Whereas, yes, the room temperature reacting antibody and the 37 degrees Celsius reaction is weaker. Okay. So since the DT was positive with your initial test, what do? Is you do a further testing with IgG and anti-C3D reagent, right? So what is it showing? The IgG component is 3 and the C3D component is +1. Correct. So that is both IgG as well as C3D. So IgG is definitely a warm component, whereas C3D is complement activation, right? It is signifying or pointing towards the cold component. Okay. So what would be your likely diagnosis?
Mixed type of autoimmune hemolytic anemia.
Right. So there is some autoantibody and it is reacting at room temperature as well as 37 degrees Celsius and also at 4 degrees Celsius. So mixed AIHA. And if you have to give transfusion to this patient, what will you consider in this case? So do you want to comment on how you would proceed?
A weak reactive sample of the blood is taken and it is washed with saline to remove the serum antibodies, and that would be the better to give to the patient.
Okay.
Titer cross match can be.
Absolutely. Yeah. So what would you do? You want to comment about titer cross match? I will just go to that slide. Okay. So as you said, there are autoantibodies. So in this case, what we did is we put up a titer, a serial doubling dilution titer of the autoantibodies, right? And we found that the titer was positive at even a dilution of 2048. Okay, so this is a significant autoantibody titer, correct? You can see these are the serial doubling dilutions here. Okay, and even till the last well, there's no point in titrating further because this is a very significant or strong autoantibody component. Okay, then what you do is that any titer, so the patient's titer of autoantibody is 2048. Okay, the other thing which I want to say over here, it may sound a little complicated, but there is also a cold antibody component, isn't it? Now that will always interfere with your test results. So what you do is you pre-warm everything. You do pre-warm testing so that the cold antibodies are ruled out. Okay, they won't interfere with your test results, right? And luckily in this patient, you had a clear-cut result for the RH KEL. Okay, so this was early onset of the mixed autoimmune phenomenon. Therefore, your RH KEL phenotype could be easily interpreted. There was no mixed field reaction or there was no pan agglutination. If you find that, then it becomes really very difficult because in such cases, what we do, since any cross-match will not be compatible at all, you pick up the same RH KEL phenotype donor units and you put up the cross-matches and you put them up at with the titer cross-match also. So any titer where you get either the best match blood or a completely matched or completely compatible result, that you pick up and you label them as the least incompatible, which is now replaced by the terminology known as best matched, right? So we could find 2 units which were best matched with low agglutination, that is 1+. Okay, these cells, they don't harm the patient in any way, but the patient kind of is salvaged because if very low hemoglobin, less than 5 grams, 4 grams and all, then you can at least clinically stabilize the patient with such a unit. And since you're giving RH phenotype matched, what happens is 70% of the antibodies would be RH type only, specific. So you are almost ensuring 70% compatibility. Only 30% chance that any non-RH antibody may be underlying those autoantibodies and that can still cause hemolytic transfusion reactions. Okay, so this is the titer cross match with the 2 units that I showed you. So you can see over here how, in the subsequent dilutions, you can see that these units are, means after the 1 in 4 dilution, you can see a clear-cut compatible result, isn't it? This is the unit number. So these units are found to be compatible at a titer cross match of 1 in 8. Okay. So the presenting hemoglobin was 5.7. 2 PRBCs which were best matched were transfused to the patient. The patient physician was also informed about this. A critical notification was sent because they need to understand what we are dealing with and how to further interpret. A hematology reference was sent, and these 2 units were transfused with a good clinical monitoring during and after the transfusion. And the hemoglobin rise was found to be 7.9 from 5.7. So a good increase in the hemoglobin, and this sustained for the next 2 weeks also. The patient was stabilized. So we know that there was no underlying antibody in this case. So 2-3 important things that we need to understand in such cases is, that how do you interpret a positive DAT, isn't it? So you have to start with your history, whether there is any pregnancy related history or any drug related history, and what are the laboratory findings like reticulocyte count, spherocytosis on the peripheral smear, any hemoglobinemia, increase in the LDH or bilirubin levels. So these are the basic things that you do. Right. And for a positive DAT, there would be 3 possibilities: if the patient had any previous transfusion or any pregnancy related history, or if there was any in vivo hemolysis history of that. So these 3 things you have to understand, right? If none of them are there, then no further examination is required, right? If any of the above 3 criteria are present, then what you need to do is you can do a adsorption elution technique, which is again very labor intensive. Many a times, practically I can say that these patients, they just present with hemoglobin of 3 or 4 grams in the emergency department, and you have to give a transfusion within whatever earliest timelines possible, right? So what you do is try to define a acceptable level of compatibility in such cases, so that you are sure that the transfused cells, though technically not compatible on paper, but they will survive when infused into the patient's circulation, right? So these are the basic things that you need to understand. So here a lot of counseling of the clinician, of the patient's family is very, very important, and taking a high risk consent for transfusion of the best matched blood. That is very, very important. Okay. Also, I wish to make this point here is that not all DAT positive cases will be autoimmune hemolytic anemia, or rather about 10% of autoimmune hemolytic anemia may be negative for DAT. So if your clinical picture is fitting into AIHA, but your DAT is negative repeatedly, you can still manage the case as AIHA, because 10% of them will still have a negative DAT, right? So this is what we generally see. The primary or warm type of IgG mediated AIHA is around 45%, and the secondary, which is associated with various lymphoproliferative diseases, is about 40%, and 15% may be drug induced. So please keep these things in mind. So here it is not only laboratory evaluation, but a lot of clinical interaction is very important, and a proper clinico-pathological correlation, right? So that is why I thought let us include this case. So any questions?
Right now,
it's very confusing.
I think it's perfect, not confusing. Thanks, Rajesh. It went off exceedingly well. In the chat box, I don't remember when we had so many questions to the teacher. So thank you so much. And if there is Vijay there, Dr. Vijay is there, not there. But Rajesh, now
I'm there.
Hi Vijay, you have any comments to make for students? You want to say anything to our young pathology kids? Any 5, 6, 4, 3 to 3 points, important points?
I really don't have much to say, because I also learned lots of things, which many times we just depend on the blood bank, that this is the problem, you sort it out at your end. And sometimes even we question them, like the question comes like, you already have got the sample for cross match, why are you asking me to poke the patient again and ask for the cross match? So the many points from my side are also clear. But one thing that I would like to tell the students is, at the end of the clinical end, we really face many times many challenges. Like it happens very frequently, at least once a month, where we have got properly cross match blood that we have received, we have given them with ideal conditions, but you start the blood and patient suddenly crashes. And then we collect them, as usual, we inform the blood bank, send the blood back, and then there's lots of cases done, and ultimately the results are nothing. Like, the blood is, we can't find any problem. Maybe it's related to non-hemolytic reactions or the other immunological reactions, afebrile reactions that we can get. But these things are very, very complicated, or rather I would say ambiguous. Many times we do not get exactly what is the reason for the patient's problems or the things like. And it's really something, I would say, a serious science. Or many times, what I was asking Rajesh, like when you were telling that after giving the blood, you may get autoantibodies or the hemolytic reactions after 7 to 8 days. And now I think that many times when we say that, okay, patient is not bleeding, there's no other problem, maybe the patient who has got bilirubin, which is reason is because of the absorption of hematoma, maybe because of some delayed transfusion reaction. And there we have to be little on our guards and get the things tested. I mean, it's really an eye-opener to me. Thanks, Rajesh. Thanks a lot.
Well, thank you. Thank you. I hope it was useful to the students as well.
There are a lot of compliments in the chat box, sir. Dr. Amit says that this is a life-saving lecture for doctors and patients. And Dr. Pratibha is saying that there should be more lectures on the same topic here. Dr. John Basil has a question. He compliments on the nice talk. His question is, if the patient is originally A positive and then he has had a bone marrow transplant with a different blood type, and now he has a different blood type from his original one, how to solve this discrepancy is what he asks.
Yeah, so in fact, this is a very, very special scenario where you have done a bone marrow transplant across the ABO and possibly even the RH phenotype also. So there are specific recommendations for the pre-transplant, the intra-transplant, or during the engraftment phase when the donor cells as well as the recipient cells are there in circulation, and recommendations separately for the post-transplant transfusion support for red cells separately, for platelets and plasma separately. But if you just need a kind of a common choice to avoid any ambiguity, then remember just one principle, that you should not be adding any additional antigen to the system of the recipient, and you should not be adding any additional antibody to the system. So antigen wise, O cells will be acceptable in all the cases, and antibody wise, AB platelets and plasma will be acceptable. So we even do cases where the donor is A group and the recipient is B group. So that is known as bidirectional incompatibility, right? The donor has got antibodies against the recipient has got antibodies against the donor. In these cases, we use O packed cells and we use the AB plasma and platelets throughout all the 3 phases of transplant till actually the group changes from A to B. I hope I've answered the question.
Yes, sir. There are more compliments in the chat box, sir. Truly life-saving for call duty doctors. Truly helpful for practicing pathologists also. Very informative session. A lot of compliments in the chat box, sir.
Thank you. Thank you so much.
I have just one more question from my side, just to ask you.
Sure.
Are there any further research done where you can probably diagnose that this patient is going to have the graft versus host disease after blood transfusion? Anything else which is new? Because the GVHD is one of the devastating complications following blood transfusion, and I've seen that case. So is there any advance on that ground?
Well, actually, the advancement is that there are now proper guidelines that are available for candidates who should be considered for gamma irradiated components. So any patient who is immunosuppressed, or having some T cell regulatory mechanism defects, etc., or newborns, so all newborn surgeries, neonatal surgeries, and all these patients, they should receive leukodepleted gamma irradiated blood to prevent TAGVHD. But the susceptibility to TAGVHD remains. It remains in even immunocompetent patients also.
Do you advise, as the cancer patients are immunocompromised by all the means? Now we do many of these supramajor surgeries, like the hypex surgeries especially, where you get extremely high inflammatory response in the intraop and the perioperative period, which is going to make them further vulnerable for the immunosuppression. Many times these patients post-operative, their WBC count drops to less than 1,000. Total leukocyte count maybe 0.8, 0.9. So in these cases, you think we should insist for gamma irradiated blood, or?
Well, definitely, at least the cellular blood components like platelets. See, the problem is with the gamma irradiation of red cells. On our side, the transfusion side, if you irradiate red cells and keep, there is hyperkalemia bound to be there, right? So with adult patients, it's not much of a problem, or if you are not dealing with a massive transfusion, it is still not much of a problem. But for pediatric patients, you better have freshly irradiated units. That directly adds a turnaround time of, say, at least about some 10 to 30 minutes to the unit being available for transfusion. So I think, from your perspective, that will be the most important factor. For platelets, we can irradiate all platelets as a policy and keep them because there is no storage lesion. There is no problem with gamma irradiation of platelets at all.
Thanks.
Dr. Tejaswini has a question, sir. If the patient's blood group is O negative and in titer cross-match, if the antibody titer is more than 64, how to manage transfusion for such a patient?
So do you mean to say that it is a O negative patient with the anti-D antibody?
I think so, sir. She hasn't specified that, but she mentions a titer cross-match.
Okay, so no, here titer cross-match is not needed. Titer cross-match is when we are dealing with an auto-antibody. Here, if you are saying that there is an O-negative individual who has an anti-D antibody and you have titrated that antibody at 64, as she says, you can clearly give a O-negative unit. You cannot give a O-positive unit because that will immediately lead to hemolysis. But an O-negative unit, cross-match compatible at IIT phase at 37 degrees Celsius is good enough.
She now specifies that it is an O-negative autoimmune hemolytic anemia patient.
Okay, yeah. So again, here O-negative units you can find with the 64 titer of autoimmune hemolytic, your warm autoantibodies. There shouldn't be any problem. You can find O-negative units. Only thing is you should have a good inventory of O-negative in such cases.
Dr. Lee asks, how does titer cross-match help in making decision in compatibility and cross-match?
So it is basically a simple funda here that the patient is having, say, autoantibodies which are reacting, say, at a certain level. Okay. What we are doing by performing a titer cross-match is we are selecting a lower level compared to the autoantibodies at which the unit is showing least incompatibility, or it is showing a complete match. Okay, so at that level, the red cells are likely to survive significantly in the circulation. They will not be coated or they will not be destroyed in the extravascular circulation also because of the coating of these antibodies. So that's basically the funda. If you have a unit that is showing agglutination or incompatibility at the level of that autoantibody, then they will not be surviving. They will get immediately coated and the patient will have jaundice also.
Dr. Sneha asks, what is the duration time to stop transfusing the mother's blood group to a neonate?
Yes, as we referred to different guidelines, the maximum is 6 months. By that time, the neonates forward as well as the reverse blood group is sorted, and you get clear-cut reactions. So you can switch over to cross-matching with the child sample without looking at the mother's blood group.
I think that's
Rajesh,
all.
one more question from my side. Yeah, this has been a very long time burning issue. Suppose if I have got a patient who is A positive or B positive or whichever the blood group, and because of the shortage, we have given the O positive or O negative blood to the patient. It's typically after massive blood loss scenarios. Can I switch this patient to his own blood group? Is there any time limit? Or suppose after giving 2 or 3 units of O positive, I get again the patient's blood group is mobilized from somewhere. Can I use it directly or how do I?
Yeah, so there are guidelines. In fact, the blood center will have its own SOP and policy for switching over when you use an alternate blood group. So what we do in such cases is that, especially when you're using O group, if it is packed cells, it doesn't really matter much because the packed cells will have very minimum plasma and anti-A and anti-B will literally be not there, right? But if you're using whole blood transfusion, then you have to definitely wait for at least 72 hours and see to it that there is no DAT positivity, or at the IAT phase your compatibility is completely clean and there are no mixed field reactions observed, and then only you can switch over.
But what if I'm using FFPs of the different group? So suppose
if you use of a different group, it will essentially be a AB group. So there is no antibody in the FFP at all.
Okay.
So absolutely okay. Only when you are using O, semi-packed cells or whole blood, then you need to be a little worried about the anti-A or anti-B isoagglutinins that may be coating the A or B cells, which is the native blood group of the recipient.
So if I'm using packed cells, nothing to worry at all. So I can just switch out within a couple of hours or something like that.
But generally, we always recommend that to at least wait for 48 to 72 hours to switch over.
Even if you have given the packed cells.
Yes, or we interpret the DAT and the compatibility results, and then it largely depends on the inventory. So if you have a shortage, less likely that you have an inventory available in 2 to 3 hours. So generally, it takes at least 24 hours to have inventory again back to normal, and then you decide to switch over.
Okay, thank you.
Thank you very much, Rajesh. Before I give it to my moderator, wonderful talk and so much patience you have to answer all the queries. And